You've been there forever and forever. People have come and gone. The sun has risen. The sun has set. You've grown a beard for those people who can grow beards. Right? The residents have gotten perceptibly older in the period of time that you've been there. Then comes the golden moment. The moment we all wait for. Please now, can I go home? In our excitement about finally being discharged from the emergency room, we forget to ask, so what was wrong with me? Right. Now, oftentimes, I can't tell you specifically, but I can tell you what I've done and why I've done what I've done. So let's say you've come in with that chest pain. Okay, let's go back to that case. You've come in with that crushing retrosternal chest pain. You thought you were having a heart attack, very legitimate. You came into the emergency. You've been there probably for about 12 to 24 hours. I've run a series of tests. I may have asked the cardiologist to see you. You may have had a stress test, whatever. The bloods have been done. I now say, you get to go home. Your response should be, thank you very much. So? If he's really stupid, you could be a little bit more clear about the question. So what was wrong with me? No. And he or she should tell you, this is what you came in with. We ruled out the probability that you've had a heart attack. We don't know specifically what it is. And this is what we think you should now do. You should never leave the emergency room without a clear idea of what should I be looking for that's a sign that something's wrong, right? So for chest pain, recurrent chest pain, something has changed. I should tell you what would be signs to come back. I should be telling you what you should be doing in follow-up. Cardiology saw you, they want to see you in a week, they want you to stay on aspirin until they see you. You should have a clear set of instructions about what we thought was going on, or didn't, and what was going to be happening to you in the next period of time, and whether you need any medications or change in your present medications. If you don't get that information, I'm sorry, you have a responsibility. Ask it yourself. Ask it yourself. There's no harm in asking a question. Yes, sir?
What could cause chest pain other than a true heart attack?
Oh, there are. The differential, as we call it, the differential diagnosis, thick like this, long like that. But I'll give you an example. Your esophagus, that tube that carries food from the mouth to the tummy, goes into spasm. The body isn't very smart. Anything in that area causes chest pain. So you'll have crushing chest pain. You may not make the association with food because it's gone into spasm. That would be a classic thing. You could have had something really serious happen. You may have had a blood clot in your leg that's broken off, that's gone to your lungs. You could have a pulmonary embolus. You could just have a bit of reflux, acid reflux. You could have nothing. So there's a whole gamut of things all the way through, from the lungs to the esophagus to the heart. So that's why I'm saying, and these are the things I'm thinking about. You ask her what we do in the emergency room. Mostly nothing. We're usually playing cribbage, depending on the age group. Hearts was a biggie for a period of time. But, you know, my specialty in emergency medicine, what I tell the residents is, I'm a specialist. But what I'm a specialist in is a few things. First, we say in medicine that when someone presents with something, you're supposed to think of the hoofbeats. When you hear the hoofbeats, you're supposed to think of horses, not zebras. In other words, common things are common. Don't waste your time thinking of stupid things. My philosophy is just the opposite. You come in with whatever it is, and I hear those hoofbeats of disease, of illness, I'm supposed to think of the weird and wonderful ones. And what I tell my residents is, rule them out. Ask the right questions. Don't order a serum cauliflower level on every, don't send them off to MRI. Think. They're presenting with this. This is the differential. It's most likely this, this, and this for the following reasons, and not these other zebras, because at least I've thought of it. So you're crushing retrosternal chest pain, you could be tearing your aorta apart. Dissection of the aorta. That's something my resident should be thinking of. And it's very simple. Blood pressure in both arms, check the pulses, do a chest x-ray. That's all it requires. A bit of thought and doing the right tests.
So how do you know if you're getting reflux or spasms?
You may not. You may not, and I don't expect you to.
So
but that's my job. That's my job. But if you have it recurrently, that's something you should have been discussing with your doctor. Your doctor should have started the workup to see whether it's reflux and this and the other things. The first episode coming out of the blue, doctor isn't available, yeah, of course. We talked about what was a reasonable thing to come to the emergency room for. But if this is a recurrent problem, my hope would be that your doctor would be looking into it. So the question was, how do I know what that chest pain is? And the long-winded answer is, it's not up to you to figure that out, but it's up to me to. That's a legitimate reason to come to the emergency room. So, we talked about what you should expect to go, to come, and all that. I just want to touch on one last thing before we open it to general questions in general. People often get really, really, really ticked off. Can I say that on video? Bothered. People get really bothered when they come into the emergency room and they're sitting there and they see other people walking ahead of them. Why is he going first? He's not as sick as I am. It's not fair. Right? Hear it all the time. You have to understand that part of what we do in the emergency room is based on how sick you are, the acuity, and that's something you may not realize. Part of it's also dependent upon patient flow. I'll give you an example. A woman comes in who's pregnant, who's having a vaginal bleed. If my gynae room is free, even though she's come in after you and she may not be all that sick, I may bring her in first because the room I need for you isn't available, but I have the room for her. I'm trying to manage the flow through my department as efficiently as possible. So sometimes part of what I'm doing is related to the acuity, the seriousness of your illness. Sometimes it's related to the flow of patients, how I can get the maximum speed and efficiency out of my department. And to be honest with you, it's an emergency room. It's not an office. You didn't make an appointment. I apologize. And I've got to try and move people through as quickly and as efficiently as possible, making hopefully not too many mistakes as I'm doing this. And we all live with that fear. You know, I was talking about the MIs. 25% of people who have documented heart attacks do not have a change in electrocardiogram. You may not. We know that even at Harvard Medical School, they miss about 2% of those true acute MIs. That's Harvard. Never. That's Harvard, right? God. I'm allowed to miss more at McGill. Actually, our rates at the MUHC are right around there. We don't think we miss many. But even one is one too many. And I'm very careful. You know, patients they go to one hospital and they go, I went to Sacre-Cœur, and you should only believe that I waited for 16 hours. You know, there, but for the grace of God, you could be at my place and the same thing would happen. We all live within the same system. There's a real problem here. Our healthcare system, the cost is incredible. They expect that the cost of healthcare in Ontario in 2020 will eat up 70% of the provincial budget if nothing is done. Right now across Canada, Quebec being an example, healthcare eats up approximately 45% of our budget. Now, so people say throw more money at it. It isn't the money. It's how the money is being used. And I think Urgence Santé is a perfect example. The problem is, as you all know, there are multiple levels of bureaucracy. And that comes out of a basic suspicion that you can't trust doctors or nurses or healthcare workers to make the right decisions about patients. And as long as you have that basic distrust, you create systems of checks and balances and paperwork and things that need to be done. There's more than enough money in the system. If the system was oriented towards patients and took it from a patient's perspective, what would work best, both in terms of prevention and management, I'm sure we have more than enough money within the system. And I'll give you a perfect example. The prevention budget doesn't come from the hospital budget. So there's no advantage for the hospital to do anything preventative because that comes out of their money and they don't get reimbursed from the government for all the Prevnar and the other vaccines that they might give. That's a loss leader for them. So there's a real mess in terms of how our system is organized. And it's a mess because patients haven't been involved. The healthcare workers have not been involved, and it's because bureaucrats have taken over the system. And I really think that's a problem. And the only reason I mention that is people in our age group need healthcare the most, either for ourselves or for our loved ones, and we're the ones in the best position to do something about it because many people are retired, they have the time to do it. The problem is if you wait until someone you love or yourself are sick, all you care about is getting better, and I understand that. I would be the same way. And then once they're better, you go, thank God they're better. You're going to leave well enough alone. In the States, gray power has been very effective at lobbying and protecting the interests of our older citizens. And older for me is over 55, and I qualify. Thank you very much. And one of the reasons why I do these talks is because many of us have been so beaten into the ground that we feel powerless within the system. And so my comment is, take charge of your own health. Be responsible for what's going on. Understand what's happening to your body. Don't be a passive victim. Ask the right questions. Demand the right information. But also stand up for what's due to you people. We've worked very hard. We've paid taxes for up-teen years. They owe us a better system. And we owe our children and our grandchildren a much better system. And if we don't do something about it now, it ain't going to get better. I'm telling you right now. It ain't going to get better. I will tell you personally, I've met with the Minister of Health, Yves Bolduc. I'm very, very impressed with some of the things he wants to do. I'm hopeful, given all the politics and the unions and the way things work, I'm hopeful he will still succeed in some of his initiatives. But at the end of the day, if something is important to you, make certain you stand up and support it in some way. Because otherwise, what happens is our own fault. So that's the end of my diatribe. I will climb down off my soapbox. As you can see, it's a very lofty soapbox, right? Huge difference in my height. And I will answer questions if I can. Yes? Let me just paraphrase this for the sake of the video. So the comment the young lady is making is that basically we should be involved. And one of the very effective ways of being involved is to be involved politically at the local level. Let's be honest, we saw what happened for those of you, for example, who live in Irwin Cotler's riding. The battle between him and Solly Seidel, it was that close. So they need our votes. They need to hear our voice, and that isn't unique. That's across the board. But writing letters and doing things, I do also want to echo something. Think about this logically. I also referee in hockey. Do you really think yelling at me as a ref is going to get a better call for your team? Do you really think yelling at me or yelling, I love this, they yell at the poor nurse and they're lovey-dovey with me. You don't think I saw what you just did to my nurse? What, you think I'm that big a hypocrite? So if you treat my nurse like dirt, let's be honest, huh? What goes around comes around. And I'm very honest with patients about that. I said, I'm sorry, I won't tolerate that type of behavior in my emergency room. But so whether it's yelling at the nurses or the orderlies, with some exceptions, I will admit, most of the staff is there because they want to be and because they want to help you. Most. I will tell you that my staff, by and large, is shell-shocked. There's not a shift that has full nursing. There's not a shift that has under capacity. We're in what we call code purple since November almost continuously, which means I think over 120, 150% capacity. It's just, so you can understand if you went into medicine because you love people and you want to make them better, and your hands are tied because you haven't got enough staff, it's understandable why their reaction might be to create a shell around themselves and to become the hardened Nurse Cratchit of fame, right? It's a natural, understandable, protective response in a loving, caring person who's blown away by what they have to deal with. And I see this all the time. So I echo everything you've said. I think it's important that we get active, that we say the right things, that we not yell at the nurses. You can yell at me, what the heck. I'm getting yelled at home, yelled at work, yelled everywhere, what the heck, on the ice, it makes no difference. It makes me feel like I'm at home and I'm loved, or on the ice and loved. So, kidding aside, that's obvious. There was a question here. She said, the other lady said most of what I wanted to say, but I get the feeling when I turn up in an emergency room, if I'm over a certain age, I don't even think it's just necessarily 65, even in the office,
in a doctor, in the hospital,
in the clinics and all that, they just tend to ignore you. I don't know. I think it really depends upon the vocation of the hospital and the people that you're interacting with. I wouldn't make the blanket statement. But having said that, I will say that you people are at a disadvantage. My system is not set up very well to deal with older people in terms of diminished mobility, diminished sight, diminished hearing. My system is not set up for that at all. And so without meaning to, we have created an environment that is not older person friendly. And that's a major problem within our emergency rooms. The idea being that if you're above a certain age and you had someone younger who kind of pushed the system a little bit, you got treated a little bit better. And I agree with you, to be honest with you. Look, I said, one of the reasons why you're bringing someone to the emergency room with you, the same way you bring them to your clinic visits, is exactly for that reason, so they can navigate the system. But I will add, our hospitals, by and large, our emergency rooms especially, are really not older person friendly or anyone who is disadvantaged in some way. So if you have a handicap in the way that you can't walk well, you can't see well, you can't hear well, you're at a tremendous disadvantage. The other comment I was just going to make is we also don't talk to you very well. I was talking about that on the radio today. And the comment being that we often talk in medicalese. We've been trained to a very high level. Most patients are not trained, God bless them, to the same level. It's probably to their benefit. But we use a vocabulary and terminology that some PhDs won't even understand, and we expect patients to understand. That's putting them at a tremendous disadvantage. So one of the things we don't do very well is talking to people in a language they understand.